Nikhil, that needs to be sorted out.
Dr. Nikhil is a MD ophthalmologist from All India Institute of Medical Science, and then he did his fellowship from LV Prasad Eye Institute. He is a third generation ophthalmologist practicing at GOKHALE Hospital, Mumbai, and he has 30 peer-reviewed publications in national and international journals. And he is a reviewer in several national and international journals, ex-president of Cornea Society of India and ex-president of Bombay Ophthalmologists Association. It's over to you, Dr. Nikhil.
Thank you, Dr. Sirish. So I'll be speaking on simultaneous or sequential pterygium surgery with cataract. So when we sit in our clinics, we see cataracts of different grades coming in. And we will see different grades of pterygium, which will be there in these patients when both are together. So it could be large, fleshy, involving center, not involving center, small, peripheral, atrophic. So all grades of pterygia will be there. In practice, we will also see patients who are coming from urban areas, from rural areas, or we may ourselves be going in an eye camp where we are going to operate. And therefore, these patients may have a follow-up compliance, which may be excellent or good. It could be poor, or maybe an eye camp situation where probably you'll never be able to see the patient again after the surgery, or maybe after a week of surgery with very limited follow-up. We will have patients who will be okay with 2 surgeries. We will have some patients who are okay with 2 surgeries, but they're not willing to pay for 2 surgeries because that increases the cost of procedures. And then there will be some where they may not be very keen to undergo 2 surgeries. Similarly, some patients may have very high visual demands after both the procedures or once we have done surgery. Some of them may be very keen to have a premium IOL. And then we might have more patients who are realistic visual demands, who understand the situation. And then we'll have some patients who may have a very low budget, or they are sort of free patients where we may have to be doing maybe an SICS via PMMA IOL. So all these scenarios come in different combinations when we sit in the clinic. And I think we need to analyze these factors before we decide what we are going to do. So before we start looking at that, just to say that pterygium is known to cause astigmatism, wherein in the axis of pterygium, there is a corneal flattening. And whenever we do pterygium surgery, this will result in steepening of the cornea and reduction of the astigmatism. Typically, whenever we talk, we keep mentioning about the length of pterygium on the cornea. This is 2 millimeters, 3 millimeters on the cornea, reaching pupil edge or involving pupil. But the other parameters which literature shows us are equally important is the width of the pterygium on the cornea, the surface area encompassed with the length and the width. And then if you have a Scheimpflug image as shown in the lower figure, the depth or the height of pterygium is also important, and the cross-sectional area as measured on this Scheimpflug image has also been tried to correlate with various factors. So typically, if you have a large and fleshy pterygium, and then we have a mature cataract, you might consider doing a simultaneous procedure, whereas with a smaller pterygium or an atrophic pterygium, you might just manage to do the cataract alone. In a patient with an immature cataract, again with a large pterygium, it's best to do a sequential surgery whereby you do a pterygium surgery first, followed by a cataract surgery. Or if the pterygium is not very significant, you could do either of them first based on your convenience. However, when we have patients where access to care or follow-up is not there, we might be forced to do a simultaneous surgery even with large fleshy pterygium with a significant amount of cataract. So just go and see some of the factors that we need to consider. So if you're doing a simultaneous surgery, we need to understand that as I said, because of corneal flattening, there will be a reduction in the measured keratometry value and overestimation of the IOL power. So if you have done a combined surgery, you will get a myopic shift after surgery. And this myopic shift could be anywhere from 0.5 to 1 diopter. So if you are really looking for emetropia, you may need to reduce the IOL power, which is obtained by biometry, by about 0.5 to 1 diopter. And you can try and approach these cases even with the SICS from the temporal side if you have a nasal pterygium, or on the steep axis, whichever is more convenient or comfortable. Just to share with you a more recent article, which as you can see on the pictures on the top, the corneal astigmatism significantly drops following pterygium surgery. This is of course we all know very well. The corneal refractive power tends to get higher. So I said the cornea will become steeper. So this may be anywhere from about 0.5 to 1 diopter steepening of the corneal power following pterygium surgery. And then if you look at the IOL power change, which can happen because of the surgical procedure, it may be up to 0.5 diopter in maybe half the patients, and another half of patients may have even more than a diopter of change in the calculated IOL power. When we look at sequential surgeries, we need to understand that larger the pterygium, by which it may be the length, the width, the height, and the area, it may take longer to achieve stability. Maybe we can start measuring the keratometry at 6 weeks and try to keep monitoring it every 2 weekly, depending upon how urgent is a cataract surgery, so that we can judge whether things are stable or not. If you are looking at a non-toric IOL or a regular IOL, I think even once the K values are stable, we can go ahead and do the cataract surgery, though the astigmatic figures or the astigmatism may continue to change subsequently. However, if you're looking at a very premium lens or a toric lens or very perfect sort of post-op result, we may need to definitely wait longer till the astigmatism component gets really stabilized. And otherwise, we are likely to get a surprise which can happen post-operatively. And maybe we need to be careful whenever we are doing a simultaneous or sequential surgery that the side ports should be not in the area of the pterygium. So this was one of the studies recently published in 21, which looked at the keratometric and astigmatic stability. So as I mentioned, keratometric stability is important when you're looking at putting a regular IOL. And at 6 months, about 75% of patients had stable keratometry values. At about 3 months, this was about 50%. Whereas when you look at astigmatic stability, it was about Whereas if you look at astigmatic stability at 6 months, it was just 40%. So they also observed that when there are large pterygia, which may be more than 3 millimeters on the cornea, there is a significant delay in the corneal astigmatic stability. And of course, we are talking of cataract surgery, but if you're looking at any sort of a refractive procedure, they mentioned that you should at least postpone it for a year till all the curvature changes are completed. So when we are looking at a post-pterygium patient where we are planning to do a cataract surgery, I think we need to do the topography to be sure that you have a orthogonal or a regular astigmatism is there. Because especially if you're trying to put a premium lens or a toric lens, if you're planning to do like that, you need to be sure that the astigmatism is proper. We know that the scar maturation can take more than a year. And we also need to evaluate the pupil and the tear film, because as mentioned, dry eye is a significant problem which can impair the expectations or the results that we get after surgery. And in patients, if your refraction axis, the topographic axis, the axis you get from the biometer and the autoref, sometimes you get all variable values in some of these measurements. And if that is happening, I think one has to be very careful and probably put in a regular lens rather than trying to put a fancy lens. And I think it's most important that we counsel the patient so as to meet expectations of what we expect following surgery. Also to mention that when you have an irregular astigmatism, it's important to see the origin of this astigmatism. So this is a patient who has an obvious dense Salzman like nodular changes, which is there following a pterygium surgery. So this definitely needs to be handled before the procedure is done. However, it can be more subtle. And I would suggest that as a surgeon, we do the keratometry or the topography or the biometry ourselves so as to look at these Myers, because they can also tell us whether the tear film is good and regular, and also shows subtle changes which may be missed by an optometrist. So if there is subepithelial scar tissue following a pterygium, sometimes it might look just like a stromal scar, but there is something which is there which can be handled and managed by doing a debridement. And we can probably get a much smoother and a regular surface and then proceed with the cataract with lens surgery. So at the end, just to say that there are a few pros and cons between these two procedures. A simultaneous surgery increases the surgical time, increases the post-op discomfort and pain. It might delay epithelial healing, especially if you give steroids, antibiotics, and all these drops post-surgery immediately. And there is definitely a chance, if some of us are still trying to do a bare sclera or a mitomycin C technique, or just sort of excision of the pterygium along with the cataract surgery, and the visual results, as we said, may be suboptimal either because of the scar or because of biometric issues, and you might get a refractive surprise. Whereas when you do a sequential surgery, you have to do 2 surgeries. The expenditure is double. The recovery time doubles up. You need to do significantly more number of follow-ups. However, this may be safer with a lower rate of complications. And basically, before you do the cataract, you know what is the extent of scar tissue, what is the extent of astigmatism, and you can have a more predictable refractive outcome. One of the very important points that you need to do is that if you are planning to do a simultaneous surgery, do talk to the patient, because otherwise it's even at the end of surgery, patient complains that you took too much of time for my cataract surgery, unlike what I've known in the past. So you cannot compare a regular cataract surgery with a simultaneous cataract plus pterygium surgery in any way. And I think this is what needs to be explained to the patient. Otherwise, they are sometimes very unhappy with your surgical procedure. So I thank Dr. Sirish giving me this opportunity. I had the opportunity to read a few more articles, which otherwise I wouldn't have done. And it's great to listen to all the experts here. Thank you.
Dr. Nikhil,